Great. Thank you. We have 2 pages of notes. So I think there was general consensus around the table that precision medicine is here and will only grow as we go forward. So we discussed at some length what are some of the current barriers to implementation of precision medicine. And I think one of the biggest challenges is getting over the fear. There are a lot of fear of new things. Medicine in British Columbia and throughout Canada tend to be very, very conservative. The stuff that we've done for 30 years, we don't want to change. So part of precision medicine is changing with data, changing with evidence. And there's great resistance just because I think, fear, inertia, whatever word you want to use. And that needs to be overcome. There's also a regulatory element that needs to be considered. A lot of the novel technologies which have been adopted in the US and in Europe and Asia have a hard time coming into this particular jurisdiction. And so those rules have to change, have to evolve with new data that are being produced. I think at the ministry level, there has to be better crosstalk amongst the various departments. This siloed budget approach probably takes away from some of the novel tools that are coming into the market. And we discussed how some of the precision medicine drugs are very, very expensive if you look at strictly from a pharmacare perspective. But if they have huge benefits, say, in saving hospitalizations, the healthcare system can potentially save money on the other side. But if there's no crosstalk between those 2 silos, then the automatic, notice would be rejection of that drug. So I think ministry and governments in general have to approach precision medicine in a different way than the traditional paradigm. From an academic perspective, I think there is great opportunity to push precision medicine at Providence and throughout BC. We have a lot of the essential ingredients to enabling precision medicine discovery. We have world-class researchers, we have leading-edge clinical programs, we have great computational analysts, and so on and so on. And most importantly, we are very well integrated within a center and across UBC. And we need to take advantage of that and develop a clear pipeline of enabling discoveries in precision medicine through biomarker discoveries and therapeutic targets. So that has to, I think, has to be crystallized further. And then during this process, engage in partnerships with industry, with private entrepreneurs and other organizations to enable this and accelerate the process. There were some, in the current environment, there are some IP issues that could be a potential barrier, and we heard a couple of examples. And this needs to be, I think, worked out between the various stakeholders, especially with UBC. I think we covered all of this. For those who were in the PM discussions, would you like to add anything else? So, in summary, I think we have great opportunity at PHC and our allied organizations to really be at the forefront of precision medicine, and we already have examples of that in HIV/AIDS and several other programs. We need to harness the power that we have and work with various partners to enable this in certain therapeutic areas.
Okay. So, Don, thank you so very much. What I'd like to do is open it up to the group. Do you have any questions for Don or those that really attended those breakout sessions around precision medicine? Exciting area. Michael?
Yes, Don. Good, thanks. Great presentation there. I see where we keep talking about barriers and what is needed to move forward. So what are the opportunities? Maybe you can enlighten us a little bit. What does precision medicine mean in your view and in the research community at St. Paul's and Providence? So maybe you can talk a little bit about the opportunities rather than barriers.
And perhaps, related to that is the need. Why do we need this? And I gave one example, but there are many examples where the current approach is to take data from clinical trials on the average mean patient. And there's no such thing as average mean patient, and accept the notion that every patient will behave just like the average. But there's tremendous variation. So for even fairly innocuous drugs like an inhaler that open up breathing tubes, I showed data that in about a third it works, in about a third it actually harms the patient, and in about a third it has no effect. So we're wasting away a lot of resources using this very inefficient average-based system. So we have tremendous need, I think, at a clinical level to enable the allocation of the right therapeutics to the right patient at the right time. So there's a tremendous need. And if done properly, there could be potential cost savings to the system. Where I think we have the advantage of enabling this is that we're in a tertiary care hospital with a tremendous biobanking capacity and a lot of human materials, well-phenotyped cohorts, great researchers, people who are very interested in this field. And also, as Keith talked about, we have a basic science laboratory where we can take molecules and interrogate it towards the bedside. So there are tremendous opportunities within the organization. And across the UBC campus, there are tremendous researchers who can collaborate in organizations. So we have the opportunity. There's a tremendous need. So those two things are a great marriage going forward.
Great. Other questions for the group? Yoel?
I'd just like to, first of all, introduce myself. I'm the executive sponsor for Providence Healthcare to the Clinical System and Transformation Project, the CST project. And before a question, I want to answer another aspect of the opportunities, and that's that we're creating a shared record across VCH, PHSA, and PHC. And that will be a terrific foundation and an incredible data asset to be able to have system data and really have a much broader base of information across the three organizations. Obviously, the patients that we all share move a lot through the system. And right now, we have a very siloed ability to look at things like outcomes and utilization data and support research. So I'm terrifically excited about that opportunity, and I think that will provide, from what we talked about earlier, an amazing foundation of a larger scale component. And I think for us, a question then is, what should the CST project be considering at this point in time while we're designing the new system to really support the innovations in precision medicine that we want to make sure we can be there for in the years ahead?
Yeah, I think the CST is probably going to turn out to be a very useful project. There are limitations though, and so CST is a foundational data system, and the conversation in BC, both in and outside of healthcare, elsewhere in Canada and around the world, has moved on beyond Cerner and CST as a standalone to that as part of an ecosystem which includes secondary data systems, which include big data systems and applications and whatnot. And Cerner itself and Epic are embracing the notion of opening up APIs to the user environment. So the new standard will be Smart on Fire, probably not HL7. And that's going to drive a whole secondary system of development in the US, which is going to go absolutely berserk once institutions have finished their requirement to comply with having put down the foundational systems, which is within the next year or so. So my question to you would be, if we're going to get going with this right away, and we've heard the expression of urgency, Cerner isn't going to, CST isn't going to be in place in St. Paul's, as far as I know, and please correct me if I'm wrong, for another 2-3 years. VGH will be perhaps a year after that, or is it sooner? I'm happy to be To be corrected if I'm wrong about this. But the question is what to do in the meantime. And in the meantime, what we have to do is open up the environment to innovation and have the blockages taken out of the way. Otherwise, the length of time that we spent in BC falling behind, as documented by our own real-life experiences and documented very carefully by the innovation panel, is going to become a lot worse. We're really behind. The US is moving ahead. Other jurisdictions are moving ahead of the US. Where is Canada, is my question to you, in terms of timing.
So the question is, from your perspective, what should we as system leaders be doing now? Even though we have a huge opportunity with CST, I agree that there is an immediacy. In British Columbia, we have right now no data standards for most of the clinical information that we're talking about combining. While it's true that you could have better interfaces and use technologies like FHIR and jump past current generations of HL7 feeds, there's still a need to map data into something that is not garbage, but actually synonymous information and common business practices. We currently have clinicians using terms that mean different things to different clinicians. We have problem lists that are very different, and they don't support someone like Dr. Sin's need to be able to really understand what the experience of the patient is, because even though you can combine data and think it means the same thing, you might actually find it doesn't. And I think there's an immediacy to the research community and the health information management community to work in earnest now, regardless of the technology, on standardizing the terminologies that are used and the clinical nomenclature that's used. And that doesn't require any third-party innovation. It doesn't require an investment. It requires people getting around the table, recognizing that they have a shared interest and in creating standards, and it requires the Ministry of Health to create a governance structure that enables those to be adopted and to drive requirements. In the American context, there are very, very strict regulations around what information is required to be reported, and the industries need that, and we don't have that landscape here. And I think we all have a role, including government, to establish that regulatory environment that standardizing of the information supports.
Yeah, Neil Fraser again, just from the lens of the federal panel. We did host a day at CIHR where we looked at the precision medicine field, and obviously there's tremendous advances that are occurring in cancer care for one and many other areas. But my question for you is, there's a high cost of precision medicine, and again, what's problematic is the place where the cost is incurred and the setting where the savings occur are separated. And so did your group talk at all about how do you, without just adding costs to the healthcare system for precision medicine, how do you harvest the savings in other settings so that, again, it's a sustainable and not a cost-plus approach?
We did speak or discuss this briefly, and we don't have any solutions, but it is a real concern, particularly at the level of the ministry, with a sort of the siloed approach. And new drugs will cost money. There's no doubt about that. But the flip side is, what's the value of the new technology or new drug? And that has to be taken into consideration. And one of the discussants indicated that in certain jurisdictions in the US, the reimbursement is contingent on that value, or demonstrating that value. So, for instance, if the drug X does not demonstrate the value, then you'll be discounted at a substantial rate. If it produces the value, desired value, then you'll be reimbursed at the correct rate or the negotiated rate. So I think going forward, we need to, as a system, think about different ways of reimbursement. And rather than just focusing on the cost, look at the value. Because everything that costs money should have value in our healthcare system. And I would say the same for the older technology, older drugs that we're using. If there's no value or minimal value, then maybe we should think about delisting them from pharmacare as an example, rather than keeping them on forever. I mean, that probably won't happen. But I mean, these are, I think, the tough decisions that the payers need to make. And just as we need to be innovative, I think payers need to be innovative in terms of their thinking. And we can promote that and champion that.
Other questions?
So I was wondering if part of your conversations, Don, you looked at precision medicine from preventative medicine to precision medicine to personalized medicine. So have you talked about how you're going to maybe solve the problem more on the preventative side? And I'm thinking 23andMe, for example. In the United States, you get a lot of genomic data, and you start solving things on the preventative side, starting with children, adults, seniors, and all that. So you can start saving a lot of money for the system by preventing, using precision techniques. Right? So, and then you go into precision medicine, like, I know, cancer or surgery or whatever you're looking, and then you're looking at personalized medicine, which is kind of the ultimate of what we probably need to deliver here, really deliver medicine on a one-on-one basis.
And we should have discussed all of those things, but given the time constraint, in fact, my first slide was, we're going to discuss precision medicine only, and this is how we're going to define it, and define it in very restrictive terms. I think we need another health leaders forum to discuss all the, because this is critical, of course. But sorry, we didn't discuss it.
Well, I don't know whether you discussed this or not, but it's relevant to the topic around precision medicine. So you were talking about what are some of the barriers, but there's a barrier even at the level of physicians who have a frame of reference from their education, from their practice, all of those sorts of things that is not oriented to practicing medicine in a precision-oriented way. So one of the thoughts I had after listening to the PMI session last summer, well, not that I had, but that Leroy Hood had and tried to put forward, and it can't get anybody to take it up, is why can't BC create a school of precision medicine so that the students that we train today and through the next 4 to 6 years, 8 years of their training, when they come out the other end, that is actually how they think. Because by then, we're really going to need to be thinking that way, and there'll be a whole cohort of people who actually can help drive the system towards that. You know, BC wants to be a leader in this, and yes, in certain areas like personalized oncogenomics, it probably can be a leader in some of the areas that you're involved in. But fundamentally, if you really want to make BC shine, build a school of precision medicine.
Too bad Dermot's not here, but I think that's a terrific idea. Yes, I'm a clinician. We are a barrier towards precision medicine. But take away the terms, precision medicine. Forget about the terms, and just look at our daily practice. We wouldn't transfuse somebody ad hoc. We would actually get a hemoglobin, and make sure that they're anemic, and then give blood to those who need it. We wouldn't give immunoglobulin therapy without checking their total immunoglobulin levels, and only give it to those who meet a certain threshold. So in a way, we've been practicing precision medicine for decades. We're formalizing it more, using a term, and using more current technologies like the omics platforms to effect it. So I don't think it'll be a big stretch for clinicians to adopt precision medicine if, A, there were tools for them to use readily without filling out 10 different forms, and B, that they understand why precision medicine makes sense for the patient in front of them. So if I'm treating somebody with COPD and I know a certain genotype responds to this very expensive drug, I will order that genotype so long as I don't have to fill out 10 different forms. And so, yes, clinicians and clinical practice can be a barrier, but I think it's a surmountable barrier, and it's probably not the biggest barrier that we face in our current environment.
If I might, it may be a good way to kind of pull this together is to follow up a little bit on the comment about the School of Precision Medicine or Personalized Medicine. And one of the things that Providence is really trying to do, and it's just now forming this, is because of the renewal, and I'm not suggesting this because Providence has to own it, but Providence can help lead, and that makes a difference, and we have the opportunity because of the rebuild. We propose that there would be a committee that will be put together that will help inform some of these big ideas we're looking at in the new facility. It would be co-chaired by a member of the senior leadership team from Providence and the Dean of Medicine, who's agreed to do that with the UBC Faculty of Medicine. It would include representatives from the different health professions at UBC. It would include representatives from the Faculty of Allied Health at SFU and Gerontology at FSU, and include the president from BCIT. Imagine now you have a set of academic partners in the room. You have a group of healthcare learning organizations in the room, and you have this tremendous opportunity to start looking at interprofessional and interinstitutional changes that might get at some of these neat things. And I think that is one way that one can move forward. And the key for us, I guess, in the way I would say is, I'm going to ask one thing is, please join me in thanking Don Sin for the wonderful job he's done. Keep poking up around here so I can get around the stand in front. The other thing I wanted to say is that's important for each one of us is to think about, now that you've heard this, we're going to stay in touch with you because we want your ideas to help us move forward. And we'd like to continue to hear from you on that and get you involved with that. The second thing, though, is I asked you to think about if you were to do one thing that would make a difference in this, what could you do based on what you have, your skills, your environment, your context? What one thing could you do? Okay? So if I might, let me call up Stephanie Harvard and your group, or however you want to do it, and give kind of an overview. And Stephanie, we're going to thank her ahead of time because of the wonderful job she did. But I don't know how many people know Stephanie is actually a PhD student and isn't one of the physicians and isn't one of the academic faculty. But isn't that fantastic? She's done a wonderful job, and you can't see her from us.
Well, thank you so much for giving me the opportunity to be here today. I really enjoyed myself, and we had a very interesting conversation. We actually had two conversations back-to-back on the same topic of knowledge translation. And I think Don's presentation touched a lot on the same concepts of knowledge translation. So it all feeds back. It's all a cycle. And the conversations that we had today, I'll just give you a couple of things that stood out to me. We talked a lot about behavior change. And we talked about how behavior change is what's required in knowledge translation, because KT is basically responding to the results of our research and making changes in what we do based on what we've found through all this fastidious research that we're doing. And that's what we want to do. We want to act on those results. So the change needs to occur at a number of levels. Some people are more focused, it seems, on how to change the behavior of individuals. Clinicians, for example, might focus on how am I going to make my patient understand the need to decrease his or her sugar intake, for example, in the context of diabetes. Other people, when faced with the same question, are focused at behavior change at another level. So, for example, how can I convince maybe the school system to not have Coca-Cola machines if sugar isn't good for kids, and so on. These are just analogies, but they come up from the conversation. In the context of what Don was talking about, precision medicine and so on, what struck me, and it relates to the conversation we had earlier, sometimes the behavior change has to come at a high system level. So if a drug is not working and the evidence is showing that there's no value to it, does it need to continue to be on the formulary for all of time? Probably not. So we talked about behavior change. We also talked about whether KT just has to do with dissemination, and it doesn't just have to do with dissemination. There are a lot of different models in which we see knowledge being uptaken by interested parties. We need to ask our community whether enough resources exist for KT, and people who sometimes realize they have a need to disseminate knowledge or to talk to the right people, to have a conversation, whether they have a place to go. And we talked to a number of people who expressed that they don't really know where to go if they have a need. Some of the members of our talk were people in patient societies, for example, that they have the understanding that there's evidence that indicates for their patient group, the people that they're most focused on right now, there are practices that should be adopted, there should be practices that should be abandoned, but they don't see those changes being implemented. So if you're in that position right now, what do you do? Where do you go? And so we talked about potentially the benefit of having a knowledge translation hub, where regardless of your particular context, you would have a place to go if you have something that you want to see change. Something that would be cross-cutting. So a group of KT specialists that operate regardless of perhaps your disease group or your particular innovation, people that understand barriers to change across different levels. So we discussed that. Allison, do you have anything that you want to add in terms of reporting back?
Yeah, just what the different ideas people had that they could
bring to the table?
To the KT Hub, and what they would like to see.
So we heard from a number of people from the private sector, and they proposed that they could offer to us insight into their focus right now in terms of their developments and the application that they see for those developments in the future, connecting with researchers who potentially are connected on the same topic. I might be, do you want to come in and perhaps summarize some of that?
So we asked people what prompted them to come to the session, what engaged them, why did they want to come and participate in a session on KT. And a common thread through it was whether they had innovations or whether they had products. What can we learn from the science of knowledge translation that will better enhance the rate of adoption and the extent of the adoption? We also asked people if they were to partner with Providence Healthcare for the Knowledge Translation Hub, what would they want to see, and what would they desire from the hub, and what would they like to bring, what could they bring to the hub. They wanted the expertise of the KT specialists that we would hire within the hub. They wanted direction specifically on how they could implement better knowledge translation science in their own worlds. And they emphasized that it was important that we have a responsibility to share our knowledge translation expertise. What they could bring to the hub was they could bring access to the relevant stakeholder groups. So patient advocacy groups like Alzheimer's or Parkinson's could bring access to those patient populations. They could partner with, bring ideas and bring other stakeholders. And in the second group, one gentleman spoke to the fact that they could bring regulatory groups to assist with the policy changes. And also evaluation, expertise in evaluation. And finally, there was, Michael mentioned that he could bring software to the KT Hub to help in accelerating the knowledge translation. And also some expertise in commercial clinical expertise. So that was it. So we had really great discussions about the different, the entire spectrum of knowledge translation, from developing knowledge to disseminating it to enhancing its uptake and then evaluating the effectiveness of the uptake. And the key message that came through everything is, you know, that you have the evidence to show that the intervention is effective. But what we need now is the evidence to show that the way that we bring that intervention into the real world is equally effective.
Thank you. Excellent. Yeah.
Again, I'm sorry, I'm from Ontario, so I'm always talking about Ontario, and apparently it's the center of all thought. But anyways, within Ontario, and I'm not sure how this happens in BC, but there's a process called health technology assessment. And that's sort of the intersection of the clinical outcomes data as well as the health economic data. So as industry increasingly is asked to finance the process, it's very expensive. And I think it's currently running at about $1 million per product that you bring forward to go through this process. And at the end of the process, then you go, like, if you don't achieve those high standards, then you're out, and there's good reason why you're out. Yeah, well, cost effectiveness or clinical outcomes, either lens, and also there's things like human factors and other things. But anyways, so assuming that you achieve all of that, then at the end of the thing, you've achieved it, or you haven't. But what's missing is this knowledge translation. And so I think in order to really make this model work, the end point has to be measured in terms of achievement of standard of care. So I wonder if you've looked at it from that lens. If knowledge translation is successful, it achieves standard of care, or it doesn't. And then, what are the barriers to achieving standard of care? Just wondering if you look at that from that perspective, because in order for industry to invest in this kind of a process, there has to be, a pot of gold at the end of the rainbow that makes it worthwhile making those upfront investments.
In order to invest in the process of knowledge translation, you mean?
Yeah, as well as health technology assessment.
Yeah, I mean, it's funny that you bring up health technology assessment. The focus of my studies is not actually even knowledge translation. I do knowledge translation more as part of my work, and my thesis is more focused on things like cost effectiveness. So there is certainly an intersection there, and I think in a lot of ways this is topic by topic. From industry's point of view, part of the knowledge translation is actually identifying maybe some of the priorities. So if something is cost effective, then it should pay off in the end to invest in the knowledge translation. Does that make sense? But I should really open it up, because I got to say, I'm not an expert, and so I'm feeling a little vulnerable.
Just use an example, Neil. Part of if you look at TAVI as an example, the health technologies assessment would include many aspects of TAVI, but what about the impact on admission rates of patients to hospital, not necessarily amenable to a TAVI procedure? So what I'm suggesting is that perhaps the knowledge translation piece allows for a broader swath of impact, other than that's just focused around the actual innovation itself. Because you're really looking at as one changes paradigms, the paradigm shifts in populations around the technology, which aren't directly affected, but which are affected in indirect kind of ways. Yeah.
Just in further response to that, yes, the key outcome measure of effectiveness of knowledge translation is in the same way that you're looking at intervention studies. You look at the effectiveness of the intervention, of the implementation of the intervention. And there was recently, in this past year, a meta-analysis of 39 RCTs on different implementation strategies. And that showed that with appropriate implementation science, with KT science, that you were anywhere from 2 to 3 and up to 12 times more successful in meeting those practice standards than without the good KT science.
Just a quick comment here. Sorry I left your session a little early, because what I would have said is that if you're thinking about creating a KT hub, keep in mind that the Michael Smith Foundation has been in this space for a fair amount of time. We've developed a number of different tools, and we're in the midst of developing a video series and stuff like that. So what I would encourage you to do is have a conversation about what makes sense for an organization like Michael Smith to be doing in this space as it relates to the whole province, and then what makes sense for an institution like Providence to, what part of this problem, because it's a big challenge, sits well in your space in a sense, and how can we work together? Because we've done, I mean, we did a couple of years ago a survey, and there was something like 1,500 people that responded to this survey. We're supporting a collaborative group of organizations that are doing this. So just, you don't need to invent the wheel or reinvent this particular wheel. I think there's lots of opportunity.
And thank you for bringing that up, because actually Michael Smith Foundation, both Gail Scarrow and Bev Holmes from the Michael Smith Foundation, we've been in ongoing communication with them in developing our model for the KT Hub, in developing the tools. We sit on the community of practice for KT, so Michael Smith has been integral to this. So we thank them for those contributions.
And you know, my dream would be that there would be a knowledge translation hub in an organization like Michael Smith and in PHCRI, and that they would communicate with each other.
And SPORE.
And SPORE. I mean, I think probably the more the better. Does that sound good, Bob?
Fantastic. Thank me, or you join me in thanking Stephanie again. And now our last group, Alan, if I might ask you and or your team to give kind of an overview.
So Sean is going to present a summary of the discussion, and then I'll present the final comments on the use case.
Thank you. You notice how Alan has effectively put me in the hot seat? You like that? It's very clever. So we were talking about virtual health. That was our discussion, and we had a group that was very diverse, very full room, lots to say, great ideas. And so one of the things that I just wanted to give some context, always about the context, for really what we're trying to do when we're looking at changing care models, right? It's like we really want to try and get the patient outside of that acute center in here. I sort of mentioned that target in terms of a model, and that's really what we're trying to do. We're trying to move them up the continuum of care and make a change. So we talked about a number of things. There again were some really great ideas brought forward, and we talked about the issues, and then we talked about the opportunities, and really tried to get to action. And we have 3 items that Ellen will speak about after I'm finished. So really, we really wanted to highlight that there needs to be some recommendations developed for regulatory barriers, because they're either not being recognized or they're not being recognized or thought about for the right reasons. So that was considered to be a significant barrier, and that actually came up regardless of which piece we were talking about. It just kept coming up and up and up, right? And so, the summary of that really would be like, how do we help government get out of the way in areas where it really matters to trying to do something like this? And that might include figuring out, like, how do we go to a fee-for-service model, or how do we go to a reimbursement model that makes sense in the context of virtual medicine? Because, of course, we're going to have to change things through the waterfall, right, in terms of the way that all that works. So we need to think about that. We've definitely said that that was a huge barrier. We felt that accountability and governance were a huge issue, not just from the perspective of actually delivering health through a virtual model, but also all the way along to bringing in partners, for example, from the private sector and procurement. How do we work with companies to commercialize effectively and do things like that? We don't have a procurement model that invites collaboration of private and public sector right now in health. And so we really need to try and develop that and understand that. We identified that as a huge barrier to progress in this. We also felt that it was important to reframe the value for the patient and the care providers. And we talked a little bit about that in the panel that Ellen facilitated, right? What's the value proposition for each patient? Michael from Mayogo asked, he said, like, how do we get things that patients will use? How do we do that? How do we get them in their hands, and will they use it? And then Anne-Marie spoke about the issues. It's like, you can have all the toys you want, they won't pick them up if you don't have the right things in place, right? So how do we get people to actually engage with the quote-unquote technology and not really see technology as technology? It's invisible. And they're just really succeeding in that environment. And that really has to come from reframing the value for patients and care providers, and doing it in such a way that people understand the WIFM. Does everyone remember what WIFM means? What's in it for me, right? We've got to be able to really think at the system level about what's in it for me. and reframe that. We also need to be able to recognize design and translation according to the technology. So, we talked about in that room, we talked about everything from, like therapeutics, molecules, and things like that, to the things that we would most typically think about if we thought about like virtual health or e-health or whatever it happens to be, right? And we said, this is not a one-size-fits-all situation. We actually need to do something that really thinks about, first of all, like top priorities. We need to be able to have the solution match with the problem and be able to find solutions across the whole spectrum of opportunities here, right? We're not just going to drop something in and it's same size fits all. That in fact is one of the issues with the system the way that it currently is. So how do we customize in a cost-effective way and figure out how to make that work across the continuum? So we also felt that there needed to be an alignment of authority and accountability, so around incentives and reducing the friction in the system. And we talked quite a bit, actually. We had the opportunity to talk quite a bit about this concept of the Academic Health Research Sciences Center and how we could get beyond cooperation to real action if we had that kind of a model, because it would take us through the entire continuum. And maybe there were some pieces there that we could actually take to action and test in something like that took it out to a broader community. We also thought that analysis paralysis was a big part of our issue. Welcome to Canada. So that's a challenge. I think that's part of a cultural issue that we've talked about before. Ellen and I've had that conversation. So we need to make sure that we're actually focusing on business models, right? Because if you have a single payer system that is also delivering care, you have this issue where innovation is just this expense that takes place. It's this complexity that's added to the system. How do you actually turn that into value? And I don't know if Dermot is still in the room, but he was talking about creating economic value by changing models. And then we talked about actually creating models for companies, right? In a single payer system, how do you actually find a way to sell something into this giant system in such a way that, that you can create value and you can get investors interested? So how do you break the business models? How do you disrupt things in such a way? And how do you really think about things and force thinking about how to find that first payer, how to find that first customer in this situation? We also talked about privacy, and that was mentioned with Yoel. He actually spoke about that a little bit. And the fact that privacy is a huge barrier, it's a huge friction point, right? We don't have a consolidated way to deal with that. And as most of you know, if something isn't well defined, if it's fuzzy, if it's gray, it's extremely difficult to create action around it, let alone investment around the things that we need to do, right? We need a good definition of what that means, and it needs to be like system-wide so that we understand how to operate in that space, because that is an absolute barrier to innovation. So we talked about that quite extensively with some really good insight. And then finally, we wanted to find a way to help the ministry pivot their operations to adapt new models of care, right? So we felt that it wasn't reasonable to just make government accountable for all of these things, and that we're not the boss of government, so maybe the best thing that we could do is actually make some recommendations for how they could actually pivot some of those models and how we could provide support to that. So with that, we went down and thought about how to move some things to action, and I'm going to hand it over to Ellen to talk about those pieces.
Thanks very much, Shauna. You did a great job in documenting and reporting back. Thank you. The gist of the conversation, like the panel discussion beforehand, was addressing the absolute unique opportunity that exists within this room, because this conversation is unlike other conversations that happen in different fora where there's theoretical bantering consideration of the issues, the barriers, and everything else. We recognize that the focus that we're allowed to have by virtue of the fact that St. Paul's is going to be rebuilt, and the lag time of whatever it is, 7 to 10 years before a new facility is going to be built, forces us to be innovative in order to not only incur the value that we need to incur within the next 7 years, but actually make up for the 10 years or so of backlog that we've had in the system broadly, as documented by the innovation panel. So there are many forces and opportunities that are totally aligned to allow us to actually move ahead within this environment. We have all the opportunity right across the street and with partners elsewhere in the region and elsewhere higher up in the province, looking at Anton and Northern Health, for instance, and with everyone else in the room, be it TELUS or everyone else. So really what we wanted to come to at the end of the conversation, where we had documented the issues and spoken theoretically about the possibilities, was to come up with an action plan. And that action plan, as a clinician or a cardiologist, I'm very accustomed to coming up with action plans and executing on those plans, because if one doesn't execute, the patient may not survive. And if we don't execute soon, the system may not survive. And so, I apologize for sounding a little bit emotional, but there's an urgency about having to get to value. And I don't in any way disagree that the CERNA project, the CST project, is a huge step forward. The question is, what does one do in the meantime? What does one do around it in order to move ahead of it? Because any system that we put in place, given Moore's law, is going to be redundant by the time we put it in place. Okay. So I'll come back to the last slide that I showed in the panel discussion. And we'd spoken about Bob Sindelar's construct of a high-capacity computation hub. And that conversation isn't idle chatter. We've really cleared the room next to the reception area in the Heart Lung Innovation Center on the first floor of St. Paul's Hospital. We have 6 desks going in there. The groups have assembled. The conversation is about how one now allows interface between tissue groups, biobank groups, genomic groups, tissue imaging groups, clinical imaging groups, data scientists and computation scientists. And it's very real. And in my view, following on from the maker philosophy, if everyone's familiar with that, how does one actually touch something in order to know that it's real? And in some ways, speaking about a space and an actual computer and actual data on a computer makes it real. And so we speak about the challenges of privacy and data science, and in the interest of full disclosure, one of the groups that's been selected to go in terms of the data solution is my group, FEMI, because we have figured out the privacy issues. We have figured out the very complex issue of data sharing across organizations while maintaining privacy and security through novel governance structures built into the metadata layer. And so these aren't idle conversations. We don't have to dream about the way things might be. We have the solution right now, and institutions in the US and elsewhere in Canada have moved ahead with our solution and with these kind of solutions. So these are no longer theoretical conversations. But as with any bigger project and bigger construct, one needs an actual use case through which to focus one's energy to make it real. And so in our conversations at St. Paul's and in our conversations with our rural partners, we came up with the notion of focusing on the biggest pain point in the hospital. When we polled the administrators at St. Paul's and research leaders and clinicians, the 3 projects that were identified, or the 3 domains that were identified as needing attention most urgently, were number 1, COPD, consistent with all the indicators throughout the country, documented repeatedly by CAI and everyone else, and every other group. COPD is the number 1 offender when it comes to readmissions, avoidable cost to the systems with appropriate intervention. Second, not surprisingly, given the status of St. Paul's in the space, was addictions and mental health, not only in our unique population, but throughout the province. And it's particularly important to find a solution for this because it's a major barrier to achieving success with the economic drive of the province, which is natural resources and energy and whatnot. If one's going to build sustainable communities in rural BC, then dealing with the problem of addictions, mental health, and housing as an adjacency is absolutely critical. And if one does it creatively, then the black hole of the economy, which is healthcare, can perhaps be turned into the opportunity for the economy. And if one thinks creatively, one can look at leveraging the infrastructure that exists. If one's going to be taking assets out of the ground in rural communities via pipelines, which themselves contain infrastructure for monitoring integrity of those pipelines, and why not use those pipelines to bring value back to those communities via broadband or whatever the case may be. Addictions, COPD is an issue that actually has a unique twist in the St. Paul's environment because there's a unique problem that presents with COPD patients and who happen to have mental health and problems of addiction. And that's our immediate community in the downtown east side, for example, but the problem is much more broad, the broader community, and the overlaps with the issues that one faces in the rural communities up north. The third domain was heart failure or cardiology, and then there's a slew of everything else. We don't have to stop anywhere. And various groups have rallied around this notion, including the rheumatology groups, including the orthopedics groups, including every clinical group in the hospital. But we wanted to start somewhere. So because of the profile of COPD as a problem, we picked COPD. We picked it also because of the profile of Don Sin and his group as the primary COPD research group in North America, not only in clinical delivery, but also, as we've heard, moving into the notion of omics and basic science and biomarkers. And so the rural group in Northern Health is particularly well organized because they've had control over their EMRs and data systems under PITO for the last 10 years or so. They have control over their data. They've formed research groups led by Anton here. It's a group called AmCare, which does chronic disease management within the GP community, utilizing a collaborative of GPs and EMRs. And the EMR group throughout the province has come together with AmCare to form an organization called the Health Data Coalition. And we've had a few meetings now over the last few weeks talking about collaboration, not only in terms of research and sharing patients, but also fundamentally sharing data and creating novel data structures on top of the EMR data at St. Paul's and as well the EMR data up north. And we've picked 3 communities to start off with. Those are Valmont, Fort St. James, and Robson Valley, together with perhaps Prince George. And the notion is that once we get the value proposition right, and that's an active point of discussion, we'll be able to gather every interested party that might want to come to the table, including government, including university, of course, including industry. And so as a tangible project, what we're speaking to then is utilizing the computational hub in the academic hub and linking it to a group which is desperately in need of access to care and access to specialist care, and leveraging that opportunity. The discussion went on just a little bit further because the closing question was, if we get this right, is there a possibility that rather about than speaking simply about catching up with ourselves and closing our own gap, if we really got it right, could we ever get to the point where we could build a model that could be replicated and perhaps sold elsewhere in the world? Because if we got it right, everyone would want it. And whatever model we build as a virtual model between the rural piece of BC and the academic hub of BC can obviously be transposed into every other environment, be it Africa or Asia or India, whatever the case may be. So can we leapfrog over our own obstacles by being creative and being very ambitious was the question. And the overwhelming answer in the room was, yes, we can.